I think that made it happen. As far as I know, it's recording. I've started recording. There we go. So let everyone know that they're being recorded. Dismiss. Thanks so much for your time, y'all. Really appreciate it. In case anyone has sort of forgotten what they're here for, we're doing just like a little lunch and learn for the next hour on opioid overdose, just sort of basics. And how to reverse an overdose in case this is relevant in your life or the lives of folks who you love, or just because you live in a city where there is a lot of sort of ambient overdose on the streets, which has been the case for me in the past. So pretty handy information, and a number of folks on my team are also absolutely experts in this and could be giving this presentation. So I know there's a lot of expertise in the room. So if you have questions, please feel free to ask them. So welcome. And just by way of sort of taking a little bit of a temperature, if you could use maybe your reactions, or, you know, just wave at me if you're on camera. How many folks here know someone who's experienced an overdose in the past? Thank you. Okay. Yeah, lots of us. Totally. Wait for some of those reactions to fade away. And how many folks have been present when someone was experiencing an overdose? Yeah, totally. Okay. Thank you. Thank you. Yeah. All right. Well, hopefully, you know, that can be um that can be a really difficult experience. And I hope that we can come away today with some information that might make it a little slightly bit less scary, if possible, at least knowing sort of how to react, how to respond, what to do, may be helpful if you're in that position either for the first time or again. So we're going to start with basics. What are opioids? Forgive me if I'm looking over here. That's just where my slide is biggest and I can actually read it. So opioids are central nervous system depressants. They slow down your central nervous system, which critically controls your breathing, right? And so they slow your breathing, and in the case of an overdose, to the point where your breathing stops, right? They're either made synthetically, as our pain medications tend to be, or they're naturally derived from the opium poppy plant. Natural opioids are also called opiates, which you may see. And so here's a list of some examples, if you're less familiar with opioids, of all of the different types of drugs that are included, anything from heroin to morphine, fentanyl, which we hear a lot about in the news right now, and over the past several years, methadone, and then a lot of your prescribed medications like Dilaudid, OxyContin, Vicodin, Percocet, Norco. If folks are on Suboxone or Subutex, buprenorphine is an opioid medication, right? So what we're going to be talking about later is naloxone, which is used to reverse an opioid overdose, and it works on all of these and any other opioid that is not listed. Okay, so there is sort of no such thing as a naloxone resistant opioid. No matter how strong it is, naloxone still works, which is really important to remember. We hear a lot about fentanyl. So what is fentanyl, right? It's about 50 to 100 times stronger than heroin. It's very fast acting and has a shorter half-life. So that is really the main sort of characteristic of what has really changed in our overdose crisis, is that fentanyl has found its way into the greater drug supply. And because it's very fast acting, you have much less of a window of time in which to intervene. And because it has a shorter half-life, people tend to use more often because it'll wear off quicker, right? And so it's the leading drug right now that is involved in fatal overdose, or, we can think of them often as poisonings. In the United States, fentanyl's found in street drugs, which may be sold as heroin, within pressed pills, which are often sold as benzodiazepines or opioids, benzos being your Xanax, your Klonopin, that sort of thing. Found in stimulants as well, but that sort of varies by region. But has certainly been found in toxicology associated with cocaine deaths, crack and methamphetamine. It's a little hard to tease apart whether fentanyl was in that drug, whether folks were using those two drugs together purposefully, whether folks were using them in succession and it just sort of ended up in their tox screen. But it's something that we want to be really, really careful about if you or anyone that are using drugs that are obtained from the street, not known to be pharmaceutical grade sort of substances. Fentanyl has been used a very long time in medical settings. It can be used safely when people know what the dose is. And that's really our problem right now, is it's impossible to know how much fentanyl is in any given sort of street supply. We do have some testing, if y'all have heard of fentanyl test strips. They're a great harm reduction tool, and it's a qualitative test, not a quantitative one. So it really tells us yes or no, fentanyl's present, not how much. And so it's really hard to moderate your use accordingly. So what happens during an opioid overdose, right? So we have all of these naturally occurring opioid receptors in our brain, and opioids bind to those receptors in the brain. It slows down your breathing a little bit. Your blood oxygen levels will drop. If there's too much sort of opioid in your brain, that lack of oxygen will eventually stop your vital organs from functioning. So your heart, your brain, those sorts of things. And within about 3 to 5 minutes of being deprived of oxygen, brain damage starts to occur, which is why rescue breathing is really important if someone's experiencing an overdose and not breathing for themselves. And intervening with naloxone as soon as possible is really important. And so this will cause unconsciousness, coma, and eventually death. This can happen from minutes to hours after a drug is used. Back when we had just sort of regular old heroin, an opioid overdose could take hours before someone ultimately sort of passed from that lack of oxygen, right? And so you had this really wide range of time in which to intervene. And with fentanyl, because it acts so fast, that window, like I was talking about, is really shortened. And so what is naloxone? It's kind of this magical unicorn drug that doesn't sound like it should exist, but it does. And it is called an opioid antagonist. It is the medication that we have to counter the effects of any opioid overdose, kind of the antidote to an overdose. It's not scheduled, it's prescription right now medication. But we have found, advocates have found ways to legalize sort of community distribution and those sorts of things. There are no effects in terms of, will I get high if I use this? What are the side effects? There essentially are none. Your kids can accidentally shoot themselves with naloxone. Your dog can get into it. All of that is perfectly safe and fine. It only impacts you if you have opioids in your system, right? It can be easily administered by a layperson. We'll talk about that later, and is typically injected either into a large muscle like your shoulder or your thigh, or sprayed up your nose to be absorbed by mucous membranes. And so how naloxone works, if you look at the same sort of picture that we had before, it has a stronger affinity to those opioid receptors, right? So it's like almost a stronger magnet. And so it kicks opioids off your receptors in your brain, and it sits there in their place and disallows opioids from binding to those receptors in your brain for an amount of time. So it'll act within about 2 minutes, and it'll last for anywhere from 30 to 90 minutes. So if you're with someone you know and are comfortable with, that's why it's really important to sort of stick around and stay with them, because depending on how much opioid is in someone's system, naloxone can wear off and you can fall back into an overdose. It blocks the effects of all and only opioids. So unfortunately, it's not going to work on the benzodiazepines, alcohol, any sort of stimulants like cocaine or methamphetamine. And when people are using, for instance, other depressants like alcohol, or in particular, benzos like Klonopin or Xanax, that can make it a lot harder for folks to wake up out of their overdose and make rescue breathing important, make medical attention important, those sorts of things. So I just wanted to add a couple extra slides since we're saving this for folks later for reference. I know this is very busy and I'm not going to read it all, but just a little bit on the history of overdose education and naloxone distribution in the United States, because it's political, right? Harm reductionists essentially have continually taken life-saving tools from the medical establishment and essentially liberated them and put them in the hands of people who use drugs to save each other's lives. And the story with naloxone is exactly the same. In the 90s, naloxone distribution, which we hear so much about, now was illegal, and the way it was distributed was often this man and many other women who were involved in this sort of underground intervention would bring duffel bags full of naloxone to any gathering, conference, meeting, whatever, and hand it out, and it would then be distributed further to people who use drugs, right? And so we are seeing a lot of efforts to expand access now. And I just wanted to sort of uplift some of the history of why it even sort of is an intervention that we know and understand, because it had just been sort of restricted to like EMS and hospital use in the past, that sort of thing. So when we talk about first responders, and we talk about first responders, right? So first responders, a lot of people think EMS, the fire department, the police. Really, when we're talking about first responders and harm reduction, we're talking about people who use drugs, right? When overdoses are witnessed, when there's someone in their presence, it's often people who use drugs who are first on the scene, who are first able and willing to intervene in that overdose, right? And there are a lot of barriers to seeking medical help, even now, where we have laws that are designed to protect you. When you call 911, there's still a lot of fear of legal consequences. So this is a large part in terms of overdose response of why we support syringe services programs, because they are extremely effective and efficient at getting naloxone directly to people who use drugs, people who are most at risk of experiencing an overdose or witnessing one. And so if you don't have a lot of resources, right, you want to prioritize your impact, and that really means people who use drugs, then other incidental bystanders, then summoned responders. There have been plenty of cases where police or the fire department or, et cetera, first responder aren't carrying their naloxone or are unwilling to intervene when they do see an overdose for a variety of reasons, right? But we know that if you are giving naloxone to someone who is going to be with someone else they love, a friend, a family member, a lover, what have you, then they're very willing and able to intervene. So folks who are at particular risk of experiencing a fatal overdose, someone who's experienced a previous non-fatal overdose, someone who's experienced incarceration, that can often affect your tolerance level. Once you get out, you might use the same amount you thought you could before, and it's just a little too much for your system. Folks entering or exiting treatment for opioid use disorder for the same reason, around tolerance. Folks experiencing homelessness, and folks who are living with HIV are also at increased risk of experiencing an overdose. So risk factors, there are many, these are 8, and we'll talk about some strategies to use around these risk factors, but many of them overlap. So mixing drugs, particularly depressants, change in tolerance, like when you're coming in or out of treatment, when you're leaving incarceration, even if you've been sick or ill for just a couple of days, that can impact your tolerance. If you have an unknown product, which is basically everything right now, using alone, because you can't use naloxone on yourself, basically, like you will either be conscious or unconscious and not able to dose yourself. Being in good physical health matters, being in good mental health matters, environment matters, and prior overdose puts you at risk, right? So some prevention strategies, if you're mixing drugs, to try and take that opioid first, try and feel the effects of that, and then make decisions regarding drinking or other substances. If you are with other folks in a group, if you can stagger your use, one person use and the rest of you wait, and sort of see how it impacts folks so that you're ready to administer naloxone if needed, and then continue on, and being extra careful with other depressants, right? In terms of change in tolerance, start low, go slow is the gold standard, right? Start with a lower dose than you usually would take. You can always put more drugs in your body, but you can't take them out once they're there. And then go slow. So that would mean, in some instances, you might use a different route of administration than you are used to. So you might snort instead of smoke, or rather than inject. If you inject, you might do a very small or a very slow shot versus what you're typically used to, right? And let it see how it hits you. Try not to use alone if possible. COVID restrictions and advice have made that advice very complicated, or at least tell someone near you that you're using and have your naloxone available, and hopefully they know how to use it. And there are a couple of hotlines, apps, these sorts of things, these new technologies that folks have developed in the past few years in response to this crisis. Never Use Alone is a hotline you can call. Someone will stay on the line with you while you use. If you become non-responsive, they'll call the EMS on your behalf. And the Brave app is similar, just as an app versus a hotline. Never Use Alone is a line that comes in English and Spanish. So that's a resource that's available for folks if needed. Using alone, sometimes we can't avoid it, or we just don't want to use with other folks for a variety of reasons, whether it be preference, shame, privacy, just preferential experience, whatever the case may be. So those hotlines and those apps, let someone know how to find you if you don't respond in a certain amount of time. If you have a trusted friend, tell someone near you that you're using. Keep a naloxone kit out and assembled if assembly is required. If you are unhoused, try and use somewhere that someone might find you, a public restroom or something along those lines. Unknown product, basically we're using universal precautions right now, assuming that everything has fentanyl in it if you've obtained it from the street, right? We do have some technologies where you can test your drugs, fentanyl test strips, but like I said, it just tells you yes or no. It doesn't tell you how much. So you still want to try and start low, go slow, especially if it comes up positive. And it depends on where you live, but a local SSP might have a more advanced technology, a mass spectrometer, or that sort of thing that can really break down what's inside of your substances. Always keeping naloxone nearby, and ideally knowing and using the same sellers so that you can have more information about your product potentially. Most sellers only know so much about their own products, right? So that's not a guarantee. That's just sort of another strategy or tool that you can have. In terms of physical and mental health, certainly if you're someone living with HIV, try and stabilize your treatment. If you've been feeling sick or feeling weak, try not to do as much or as much as quickly as you normally would. Stay hydrated, eat, sleep, take meds for chronic conditions. Same with mental health. If you're prescribed meds, try to take those regularly and try and gauge your use. Like, can you use a little bit less in a way that can sort of dull a pain or an experience that you're having, but not so much that it sort of takes you overboard and into overdose, right? And your environment. So using in a place you're unfamiliar with, in a place you don't feel safe, or with people that make you feel unsafe, puts you at greater risk for overdose, it turns out, right? So if you can use somewhere that you feel comfortable with people who make you feel safe if others are there, and somewhere that minimizes any kind of law enforcement interaction, especially if you're unhoused, that is ideal in terms of preventing overdose. So the overdose itself, right? Signs and symptoms. So folks are going to be non-responsive to voice or to touch, which means that they can't be woken up, right? Shallow, slow, or weak breathing, or no breathing at all. This may come with like choking, gurgling, or like often snoring sounds. Blue lips or nails, fingertips on fair skin. The darker your skin gets, the more that blue is going to look a little grayish. Pale skin or cold and clammy skin, a slow heartbeat or a low blood pressure, and pinpoint pupils, right, are all things that you might look for. You might not need to see all of these things. If someone's non-responsive, they're not really breathing well, and you maybe see a little tint of blue, that's enough, right, to assume that someone's overdosing and you want to maybe respond to it. Ways not to respond. So there are a lot of myths that circulate around things that will bring you out of overdose. And it turns out that those are really, really unhelpful. Extreme pain or violence, hitting, kicking. I've heard people like slap. I've seen people get slapped in the face. I tried to kick him in the balls. Like, none of those things, they will just wake up in extreme pain on the other side of their overdose. So don't do that. Injecting a stimulant does not ultimately work, so don't inject them with, cocaine or meth if you have that. Injecting milk or salt water also does not work. An ice bath is the opposite effect of what you want to have. That cold keeps things breathing slow and those sorts of things present, and that's really the opposite effect that you're intending, right? So none of these things, if you've heard other myths, please share in terms of what not to do. What to do is first try and wake them up, see if they are actually overdosing. They might just be in a heavy nod, as folks say, like they might just be really high. They might just have a lot of opioids in their system. And so if you know them, yell their name, yell, I'm going to Narcan you, answer me. Most folks who use opioids know what Narcan is. And if they're awake, they will respond to that, because if you give someone naloxone who is not overdosing, you will just throw them immediately into withdrawal, which is really painful, and people want to avoid that, so they will respond to you. If not, you'll want to do a sternum rub. Your sternum is this bone right here on your chest, straight down the middle. You'll take these 4 knuckles here and rub them really hard into someone's sternum. If you do it with enough pressure to yourself, you can tell it hurts. It hurts a lot. You can pinch their fingertips. You can do the same rub with your knuckles on the upper lip right here. Those are all really, really painful, but they will not cause damage, right? And that's sort of what you're looking for. And if they're not responding to a pain response, then you can assume they're overdosing and use naloxone. Again, it's not going to hurt them. at all if they haven't taken opioids, so there's no risk. And if they have, there are no side effects except they might experience withdrawal when they do wake up. The general advice is certainly to call 911. I would say do that if it feels safe. We know that police are just out here running a little wild in some places, that folks who are Black or other people of color run the risk of a violent encounter with police. So this is really up to your discretion around your and this person's safety. But generally, calling 911 is the advice. If you do call 911, do not say it's an overdose. They tend not to respond, or not to respond as quickly, unfortunately. Mention that someone's unconscious, mention that they're not breathing, but don't say that they're overdosing, right? Because of the stigma around this. You'll administer 1 dose of naloxone, let that work for 2 minutes. If you give them another dose more quickly, it's not going to make it work faster. It takes as long as it takes, unfortunately, and that's going to feel like a really long 2 minutes probably. If they're not breathing at all, you can breathe for them. You can perform rescue breathing, which is really simple. You don't have to do chest compressions. It's not full-on CPR. You just want to put them on their back, tilt their chin up, look for anything that might be obstructing their airway in their mouth, right? And if nothing is, pinch their nose closed, 2 big, quick breaths through their mouth, and then 1 breath every 5 seconds. I have heard a story of some folks whose friend was overdosing. They were too afraid to take him to the hospital. It was an hour to the nearest SSP, and they rescue breathed for him for an hour, alternating because it is exhausting, and got him naloxone at the SSP, and he survived, right? So it's really about keeping oxygen flowing to your brain. If that 1 dose doesn't work after about 2 minutes, administer a second one, and you can continue rescue breathing. In almost all cases, it really just takes 2 doses. When you hear about overdoses that needed 7 doses of naloxone to be reversed, or, X, Y, and Z, like all of like this extreme sort of amount of naloxone, there tends to be one of a few things happening. Either there's an underlying health condition. In one case, the gentleman had pneumonia sort of underneath the overdose, and that made it hard for him to come out of it. In other cases, folks panic and they just sort of do dose after dose without waiting the 2 minutes. So it's unclear how much was actually needed, but usually 2 works. And then you're just going to want to monitor and support them, because, like we said, naloxone only lasts about 30 to 90 minutes. If you have to leave for whatever reason, some folks are afraid of the police coming with EMS. Some folks, they just literally, for whatever reason, have to be elsewhere. Put them in the recovery position, which is pictured here. One of their hands is supporting their head to make sure that if they vomit, they don't choke. And the knee, like it says, stops the body from rolling onto the stomach. You don't want them face down. You don't want them face up. This is sort of, will keep them stable until someone's able to get there. So naloxone administration is very, very easy. Let me see. Let me stop sharing real quick so that my screen can be a little bigger. So this is sort of the original naloxone. It comes in a little vial like this, and this is for an intramuscular injection. If you had this type of naloxone, it would come with a needle, and it is usually about 22 or 23 gauge. It's usually about 1 inch or 1.5 inches long. And you'll just take this little capsule, pop the orange cap off, flip it upside down, pop the cap off the syringe, which I'm not going to do because I don't want to waste this. Draw it up, and you're ready to deliver an injection, either in the shoulder or in the thigh. This, if needed, can go through clothing. And because it's going into a muscle, it's not going into a vein, you don't have to worry about air bubbles or anything that you see sort of on TV with the flicking of the thing and all that. If you're interested in getting some naloxone from me, that I can send you, it'll be a nasal spray, which is what I was very generously donated from a good friend. That'll look like this. It comes in just a little sealed package. You'll tear sort of this back part off. It's just a foil. Inside there are some elaborate instructions just in case you forget. And then you just have this little guy here. And all you do is you're going to want to tilt their head back again, just so it doesn't spill out. They're obviously not inhaling it because they're unconscious. You want it to absorb through their mucous membrane. So you tilt their head back, stick this up one nostril, press down on this pink plunger, and then you're done. If you're administering a second dose of naloxone, use the opposite nostril from the first one that you used, right? And then that's basically it. If you are injecting someone with naloxone and they're a little bit larger, there are some tips here, depending on the sort of layer of fat that is above the muscle, because ideally you're going to want to get into the muscle to like really sort of spread the skin right where you're injecting. Use like a solid 90-degree angle, use a longer needle if possible, and not sort of bunch up skin, because then you're getting further and further away from the muscle where it needs to be. Okay. And let me share this screen again. So when folks are revived, they can really be experiencing like a very huge range of emotions. They may be angry, they may be embarrassed or feel shame, they may be in withdrawal, so they're just feeling sick generally. They may be totally confused because one minute they were doing whatever they were doing and the next minute a stranger or someone else is hovering over them, right? Really, you just want to try and be gentle with folks. If you know them, that's easier. If they're a stranger, you know, just, hey, welcome back. Like, how are you feeling? Are you okay? Try and make them feel comfortable. If there's a crowd, if you're on the street, try and get those people away. It's not a spectator sport, right? And I wouldn't necessarily expect or need gratitude because of all of the like flood of emotions that people are feeling. They may not have a thank you for you. And that needs to be okay, right? And if you know this person, that may not be the case, but it's just something to potentially expect from folks. And let's see, if folks are interested in getting a couple doses of nasal Narcan, you're very welcome to email me. I've got my personal email here. If you'd like to sort of keep it off list, so to speak, you can reach me at my AU email. You can chat at me. You can text me, whatever the case may be. Caitlin, these are for some questions that you had that were excellent questions. Thank you. There is not a particular temperature at which things go bad. Try to keep it out of extreme heat or cold. Like if you're not comfortable, naloxone's not that comfortable either. And there is some evidence that even through extreme heat and cold episodes, that naloxone stays stable. It's like this one, it's like a wonder drug that I really can't believe is real, but it is. And in terms of its effectiveness and expiration, pharma companies have to put an expiration on products. They especially want you having more. But there is good evidence that naloxone stays viable for up to something like 30 years, which just get your doses now and you'll never need it again if you don't have to use it. And if you're using IM, these little vials, essentially, unless it's cloudy, you're good to go, right? So that's sort of how you can tell. And then if you need access later, something like that, in a lot of places, depending on where you live, you can do that through the pharmacy. Insurance may cover some of that cost. You can ask your local health department. For folks who use drugs, syringe services programs may be available in your area. And if not, Next Distro is a good resource also for folks, prioritizing folks who use drugs. Okay, so my throat's a little dry. Oh, we're gonna stop. I'm gonna stop sharing unless anyone wants me to revisit some slides. I'm gonna also stop recording.